Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and wonderful audiences around the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Hidenori Suzuki. Dr. Suzuki is the professor and chairman, Department of Neurosurgery, and vice dean of My University Graduate School of Medicine, Su, Japan. In addition to his clinical practice in hospital, Dr. Suzuki is also an active neuroscientist and has more than 25 years experience in clinical research, primarily investigating the vascular disorders of the brain, specifically on subarachnoid hemorrhage and vasospasm. His research findings have been published in about 300 papers on premier journals. He is also a recipient of many awards and honors for his research excellence in his career. He is the counselor and delegate of several important organizations across Japan, and we're extremely honored to have him today at our webinars. And today we'll be talking about delayed cerebral ischemia in aneurysmal subarachnoid hemorrhage, present and future. The speaker for the second session of today is our honorable guest from China, Dr. Cheng Chao. Dr. Chao is an assistant professor of neurosurgery at the Huashan Hospital, Fudan University, Shanghai, China. He is mainly engaged in pediatric neurosurgery with a focus on central nervous system tumors in children. He is a core member of the pediatric neurosurgery team at the Huashan Hospital. He is also the executive secretary of the Pediatric Neurosurgery Alliance of the National Neurological Disease Medical Center and member of the Pediatric Neurosurgery Group of the Neurosurgery Branch of the Shanghai Medical Association. We are extremely honored to have him today at our webinars, and today he'll be talking about endoscopic transnasal approaches for skull-based lesions in children. The chair for the first session of today's webinar is an honorable guest from the United Kingdom, Professor Daniel Walsh. Prof. Walsh is a consultant neurosurgeon, visiting senior clinical lecturer at the King's College, London, who has a special interest in wide range of brain and spinal diseases. Particularly, his expertise is in vascular neurosurgery. He is the South Thames Training Program Director in Neurosurgery and is a member of the National Neurosurgical Selection Panel. He is a reviewer for several international neurosurgical journals and is a member of the editorial panel for two. He serves as an elected representative on the individual member committee of the ACNS. Through the British Neurovascular Group, he has contributed to interdisciplinary training in neurovascular surgery and national audit initiatives. We are extremely grateful to him for accepting an invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is an honorable guest from Japan, Dr. Hirotaka Hasegawa. Dr. Hasegawa is an associate professor in the Department of Neurosurgery at the Saitama Medical Center, Saitama Medical University, Japan. He is an endoscopic skull-based surgeon who has abundant clinical and research experience in endoscopic surgery for skull-based lesions including pit nets, meningioma, chordoma, and chondrosarcoma, as well as stereotactic radiosurgery for brain neoplasms and vascular malformations. He was a past fellow of the Mayo Clinic Neurosurgery in Minnesota, USA, and he has been honored with several awards and honors during his career in neurosurgery. We are extremely grateful to him for accepting an invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my cohort for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Daniel Walsh.
Thank you. Hello to everybody who's watching from around the world, and my sincere thanks to the organizers for the privilege of introducing our first speaker today. Now, Professor Hidenori Suzuki is professor and chairman of neurosurgery at Mie University in Japan. We all recognize aneurysmal subarachnoid hemorrhage as a treacherous disease that robs young and otherwise healthy people often of their lives and their independence. Sometimes that's despite having survived the initial hemorrhage and come through having the aneurysm secured successfully. The phenomenon of delayed cerebral ischemia is experienced differently by neurosurgeons in different healthcare systems around the world, and I've seen that myself as I travel. Those of us who work in a system where there's continued clinical contact after aneurysm treatment will have experienced the loss of a patient to stroke sometimes up to 2 weeks after the initial hemorrhage. But since the Brandt trial in 1989, which introduced the use of nimodipine against a background of other failed trials in calcium channel antagonists, there have not really been any great forward. And many promising laboratory investigations have not translated into significant clinical effect when tested in clinical trials. So medical management continues to vary considerably around the globe. We still struggle to even agree on the definition of the condition itself. Um, are we making use of too many resource intense manipulations in the critical care setting that don't translate into clinical outcome benefit? Are catheter-based interventions evolving and capable of delivering more in terms of salvage intervention? And where are the next pharmacological agents that are going to help us mitigate this problem? Professor Suzuki will offer us his insights into that, where this field is going. So I'm going to hand over to him for that. Thank you.
Thank you, Dr. Walsh, your introduction. In recent years, there have been significant advances. Our understanding of the pathogenesis of cerebral ischemia after cerebral hemorrhage. In addition, clazosentan, selective endothelin receptor A antagonist, became clinically available in Japan in 2022, ahead of the rest of the world. So today I would like to talk about the cerebral ischemia after cerebral hemorrhage based on our recent advances. This is my COI. The incidence of cerebral hemorrhage not so high, but outcome is still poor. Overall mortality rate is about 51%, and the significant morbidity is 1/3 of survivor. As you know, prognostic factors include advanced age, admission, poor clinical grade, and there is cerebral ischemia, and so on. Recently, we received some disappointing news. According to Japan Stroke Data Bank, the outcome of a patient with cerebral hemorrhage at the time of discharge actually have worsened during the last 20 years. The main cause is advanced age. In fact, Japan is the country with the fastest aging population in Asia. What is the problem with aging? According to our registry data, advanced age is associated with more premorbid disorder and worse clinical admission grade. Also, higher age is associated with more systemic complication, leading to more delayed cerebral ischemia and worse outcomes. Delayed cerebral ischemia, DCI, is the most important intervening factor affecting outcomes. But according to publication, the incidence of DCI itself has not significantly changed during the last 20 years. So we have to overcome the DCI. DCI is now considered to caused by cerebral vasospasm and cerebral microcirculatory disorder. If cerebral vasospasm, delayed cerebral ischemia, or delayed cerebral infarction occur, the risk of death doubles, and the risk of poor outcome or cognitive impairment increases by approximately 3 times. So, what kind of prevention measure have been taken about DCI or vasospasm in the past? Early surgery, triple H therapy, nimodipine, or the Guelph-Fastio, intraarterial injection of vasodilator, clazosentan, edralone, lumbar drainage, and serostazole have been reported. Among these, some drugs are reported to be ineffective in a randomized clinical trial. Nimodipine is covered by insurance in Europe, in the US, and South Korea, while the Fastgel and Ozagrel are covered by insurance in Japan. However, unfortunately, this drug did not significantly reduce the incidence of DCI, as mentioned earlier. Among these, the drug that has been attracting attention over the last 20 years is clazosentan. However, we are shocked by the failure of conscious trial. In the trial, nimodipine plus clazosentan prevented angiographic vasospasm in a dose-dependent manner, but failed to improve outcome compared with nimodipine monotherapy. What went wrong? Two possibilities are considered. First, nimodipine plus clazosentan were associated with more side effects, including pulmonary edema, anemia, and hypotension. And the second, delayed cerebral infarction can also occur due to causes other than cerebral vasospasm, namely microcirculatory disorders. And clazosentan may have no additional effect on the effect of nimodipine on microcirculatory disorders. However, there was some good news. The failure of conscious trial has revolutionized some research. That is, clinically, the failure of conscious trial led to a change in the definition of cerebral vasospasm by a multidisciplinary research group in the United States. First, cerebral vasospasm is now evaluated based on morphology only, that is angiography, transcranial Doppler, and so on, and described as angiographic vasospasm. Delayed cerebral ischemia is diagnosed based on symptoms thought to be due to cerebral ischemia and exclusion of causes other than cerebral ischemia, without taking into account the prevalence or absence of angiographic vasospasm. Delayed cerebral infarction is caused by angiographic vasospasm and vasospasm unrelated to cerebral microcirculatory disorder. So now the term symptomatic cerebral vasospasm has disappeared from the AHA guideline. This makes it possible to eliminate the subjective differences between whether symptomatic due to microvasospasm or not, or when both symptoms and the vasospasm are present. In basic research, the failure of conscious trial led to the introduction and the dissemination of the concept of early brain injury, EBI. The term EBI is a concept to explain acute pathophysiological events that occur in brain before onset of cerebral vasospasm within the first 72 hours of aneurysmal hemorrhage. Some researchers consider EBI may be more important than cerebral vasospasm for outcomes. And EBI may cause delayed cerebral ischemia due to microcirculatory disorders. This slide shows the relationship between early brain injury and delayed cerebral ischemia. EBI is a global event occur overall brain. It's caused by elevated intraocular pressure induced transient global cerebral ischemia. And liquid component at platelet leaked into the subaqueous space. And the cerebral ischemia is a focal event of ischemia. It's caused by vasospasm, microcirculatory disorders, including microvasospasm, microthrombus, neuroelectric disturbances. DCI is caused by locally enhanced neuroinflammation, glutamate and hemolysis related reactions. Our understanding of the pathogenesis of cerebral vasospasm was largely established by the 1980s to 90s. Cerebral vasospasm is considered to be caused by abnormal smooth muscle cell contraction by spasmogen, impaired endothelium-derived vasodilation, and intravascular dehydration. And when ischemic symptoms occur at the territory of spastic vessel, we once called symptomatic vasospasm, but now vasospasm is known to be only part of delayed cerebral ischemia. The pathology of delayed cerebral ischemia is complex, and not only by cerebral vasospasm occurring in the subacral space, but also a microcirculatory disorder, including inflammation in the arteriolar wall, microthrombi, microvasospasm, and vasogenic edema induced microvessel compression and neuroinflammation that caused by blood degradation product penetrated into the parenchyma. And clot-induced obstruction of the meningeal lymphatic drainage and the glymphatic system lead to a prolonged retention of blood degradation product within the interstitial cavity. And these cerebral microcirculatory disorders lead to impaired cerebral autoregulation and neurovascular coupling. The fact after subacute hemorrhage, the circulation of CSF is impaired not only in the subacute space but also in the brain parenchyma has been demonstrated by animal study. In monkey, if we inject contrast medium into the CSF, contrast medium rapidly enter into the brain parenchyma via the perivascular space. But after subacute hemorrhage, blood failed to enter the brain parenchyma because the perivascular space was filled with blood, and the blood blocked to enter the contrast medium into the parenchyma. In mice, in this experiment, albumin labeled with green fluorescent dye was injected into the CSF. Then, within 30 minutes, albumin can enter the parenchyma via the perivascular space. Molecular weight of albumin is about 66 kilodalton, and molecular weight of hemoglobin is about 65 kilodaltons. So this means after subacute hemorrhage, hemoglobin also can enter the parenchyma. In short, mild subacute hemorrhage cases, DCI caused by only by cerebral vasospasm. So larger the amount of subacute hemorrhage, the more severe cerebral vasospasm. To develop DCI, severe angiographic vasospasm is needed. On the other hand, even if angiographic vasospasm is severe, angiographic vasospasm may be sometimes asymptomatic because microvasodilator disorder secondary to EBI is not does not occur. In severe cases, DCI is caused by a combination several microcirculatory disturbance secondary to early brain injury and angiographic vasospasm. So DCI may occur even in mild angiographic vasospasm cases because several microcirculatory disorder secondary to EBI occur. The molecular mechanism of DCI is very complex, but main actor is oxyhemoglobin, free radical, and inflammatory substances. And many cells, such as smooth muscles, vascular smooth muscle cell, endothelial cell, astrocyte, neuron are involved in the mechanism. Endothelin 1 is also important mediator, and actually endothelin 1 is involved in the smooth muscle cell contraction, brain-blood barrier disruption, and cortical splenic depolarization, also neural injury. So if a clazosentan endothelin A receptor antagonist can reach these reaction sites, that means clazosentan can be effective against not only cerebral vasospasm but also microcirculatory disorders. In 2022, two randomized phase 2 trials was reported from Japan. The subject was a Japanese patient with less than 75 years old and preoperative WFS grade 1 to 4 and Fisher group 3. Clazosentan was administered at a rate of 10 milligrams per hour from within 48 hours to 15 days after subacute hemorrhage. Many medications were prohibited, including fastil, ozagrel, milrinone, nicardipine, astatine. Rescue therapy was permitted. As a result, clazosentan significantly reduced delayed cerebral infarction due to vasospasm and also by any cause. And clazosentan significantly reduced all causes of morbidity and mortality and poor outcomes. So after the result of this trial, clazosentan was approved in Japan. But we have to pay attention to the side effect by clazosentan, including pulmonary edema. In 2023, Japan Stroke Society guideline recommended clazosentan in addition to fastil and ozagrel as a drug against cerebral vasospasm. With the approval of clazosentan, how was the postoperative management of subacute hemorrhage changed in Japan? Since 2013, we have been conducting a registry study of annual subacute hemorrhage in Mie Prefecture. The main hospital in Mie Prefecture in Japan are affiliated to Mie University, so I think this registry helped us understanding the actual situation of cerebral hemorrhage treatment in Japan. The mean age was about 65 years, and 25.8% was more than 76 years old, and 22% patient had WS grade 5. the medication have been dramatically changed. In knee prefecture, Cilostazol and Fastil were mainly administered before clazosentan approval. But after clazosentan was approved in 2022, Fastil was replaced by clazosentan. Cilostazol was still frequently used. Orzazgrel has not been much to be used to begin with. Treatment outcome are also published in recent year. This is a single-center retrospective study from Konan Hospital in Japan. This study compared the treatment outcome of Fastil plus Cilostazol treatment with clazosentan treatment. Management was changed after the introduction of clazosentan. That is, total volume was 2,000 to 3,000 milliliter per day before clazosentan treatment. But after clazosentan treatment introduction, the volume was reduced to 1.0 milliliter per kilogram per hour, and water balance was strictly limited, less than plus 500 milliliter. Rescue therapy was similar. The background factor was not significantly changed, including age and severity of submacular hemorrhage between the two groups. As a result, clazosentan significantly reduced moderate to severe vasospasm, especially distal vasospasm, and vasospasm related to infarction, the incident of rescue therapy, and improved outcome. However, even using the modified systemic management protocol, still the clazosentan group had more commonly associated pulmonary edema and body weight change, body weight gain. So we have to pay attention to these side effects. Recently, REACT trial result was published. Then we are shocked again because the treatment also failed. That is, nimodipine plus clazosentan failed to improve 12-week outcome compared with nimodipine plus placebo. What's wrong with the REACT trial? In the REACT trial, clazosentan significantly reduced the incidence of rescue therapy as expected. So we have to consider other reasons. The REACT trial was conducted in non-Asian people and had more frequent co-administration of nimodipine and higher dosage of clazosentan and delayed start of clazosentan therapy. Maybe the combination of nimodipine and higher dosage of clazosentan cause more frequently hypotension, and the combination of hypotension and the delayed start of clazosentan failed to decrease delayed cerebral ischemia compared with Japan South Korea joint and the Japanese phase 2 trial. Also, in the REACT trial, the placebo group has about 11% higher incidence of coil treatment. as you can see, coil treatment reduced rescue therapy and vasospasm related cerebral infection. So even in Japanese phase 2 trial, coil treatment failed to get a significant difference in rescue therapy and cerebral infection incident. So maybe the frequency of coil treatment failed to see the difference in the outcome difference in the REACT trial. However, maybe the most important point is the incident of prematurely discontinued treatment. That is, in the REACT trial, discontinuation of clazosentan was significantly more frequent than placebo group, while the frequency of discontinuation was not significantly different between the two arms in the Japanese South Korea and the Japanese phase 3 trial. In summary, common thread between the REACT and the conscious trial is the use of nimodipine combination. The frequency of side effect was the same in the REACT trial and the Japanese phase 2 trial, but the definition is unclear. Side effect as well as discontinuation of clazosentan may have a negative impact on the outcome. Recently, a post-market survey of clazosentan in Japan was published and found an increase in side effect when used in combination with other drugs, such as Fastil, nicardipine, and cilostazol. Interestingly, when compared the side effect by administration period, the incidence of oral and fluid retention related side effect related side effect was significantly reduced in the last 1 year. So when administering clazosentan, this finding suggests needing the familiarity with systematic management. So I will introduce the effort you have made in systematic management from just before clazosentan was approved to the present, more than 2 years after clazosentan approval. Before clazosentan approval, we administered a large amount of fluid, about 4 liters per day, including oral intake. And we administered Fastil to prevent vasospasm, and cilostazol to prevent cerebral microcirculatory disorder, and peramparel to prevent neuroelectric disorder. This is our current protocol. After clazosentan introduction, the total amount of fluid infusion, including oral intake, is reduced to 2 liters per day, and the diuretic furosemide is actually administered. And water balance was strict. Water balance is strictly reduced, controlled to less than plus 500 milliliter per day. Also, we consider blood pressure control is very important. Many SH patients has a history of hypertension, so if blood pressure decreases, urinary volume was easily reduced. So even using vasopressin, we have to control blood pressure. Basically, medication include clazosentan, cilostazol, and penampalel. This is the typical elderly case of WS grade 5. During surgery, there was excessive fluid infusion. So, in addition to clazosentan, cilostazol, penampalel, we administered furosemide. This furosemide administration improve the water balance. So clazosentan was completed without delayed cerebral ischemia. No pulmonary complication occurred. More importantly, all the drug except clazosentan was administered orally. So the workload of the nurses was minimal. Next, we investigated the penetration of clazosentan into CSF. In 23 SH patients, we collected peripheral blood and CSF simultaneously and measured clazosentan concentration by gas chromatography. As can be seen, clazosentan has a CSF penetration rate several percent, and when administered for 1 week or more, the penetration rate stabilized at about 5%. As to age, there was a tendency for clazosentan to penetrate better into CSF in patients with 76 years old or older, about from 6 to 11%. As to admission WF grade, there was a tendency for patients with worse grade, especially grade 5, to have better CSF penetration of clazosentan. In this slide, we compare the CSF penetration of clazosentan with and without DCI in grade 5 patient. The patient with no DCI tended to have higher CSF penetration. In some cases, the CSF penetration rate was good as half to 1/3 of the blood concentration. So we investigated the significance of a small percent of clazosentan penetration into the CSF in a mouse SH model. We introduced SH by injecting autologous blood collected from the tail into the prechiasmatic system. Clazosentan was administered continuously for 24 hours using a pump inserted in the lateral ventricle, so that the concentration in the cerebrospinal fluid was 2 to 50%, the peripheral blood concentration. This photo shows ink was spread throughout the subarachnoid space after the ink was administered intraventricularly. we examine the effect of intracerebral administration of clazosentan on neuroinflammation by Western blot, measuring IVA1 level. As you can see, 50 to 10% clazosentan significantly reduce neuroinflammation. Also, 2% clazosentan solution also tended to reduce neuroinflammation. These findings suggest clazosentan may be effective against pathology other than vasospasm. This is a comparison of CT perfusion finding during the so-called vasospasm phases. This is our initial clinical experiences. We compared the CT perfusion finding between the conventional, our three drug regimen, facilitazole, penampalel, and the clazosentan add-on treatment group. Clazosentan failed to reduce the degree of vasospasm, but significantly improved cerebral blood flow and mean transit time. This means clazosentan can improve microcirculatory disorder as suggested in animal experiment. However, we have carefully managed systematic condition, reduced infusion volume, and keep urinary volume, and administer more amount of blood transfusion, albumin and furosemide. Finally, I would like to emphasize again overcoming side effects is important to maximize the benefit of clazosentan. But at least clazosentan may be effective against several microcirculatory disorders and have an add-on effect on cerebral perfusion imaging compared with conventional treatment in our institute. So we have to continue to study the effect of clazosentan on DCI pathology other than vasospasm. But if we can maximize the benefit of clazosentan, I think we can improve the outcome of hemorrhage. Thank you for your attention.
Thank you very much, Professor Suzuki. That's a really interesting talk, not least for me coming from a part of the world where clazosentan isn't licensed for use to prevent DCI, and it's really not on the horizon, given the outcomes and things like the REACT trial. The Endo and Fujimura trials document a very large treatment effect on the primary outcome, effectively halving the primary outcome. And you explored some of the reasons why that doesn't tally with the outcomes in conscious and so on. And I thought you made a really valuable observation about the importance of drug interaction in the clinical setting. So with that in mind, I was struck by the use of drugs like non-competitive AMPA inhibitors as standard anti-seizure prophylaxis in your patient population, which again would not be the case in my setting. And to me, the drugs like that seem relatively new and relatively untested, and there's relatively little comparative study with their interactions with other agents, even their comparative effectiveness against other anti-epileptic medication. So I do wonder to what degree that drug interaction is a factor, whether it's benefiting the patients or not. But if I may make one more observation, when one goes back to the Brandt study, the British nimodipine trial, the primary outcomes used there were of cerebral infarction, which admittedly is an imaging outcome, but it is a hard outcome, and 3 month clinical functional status defined by MRS or Glasgow Outcomes Scale. Since that time, we've moved far more with subsequent trials to relying on primary outcomes made up of composite imaging and physiological measurements, sometimes with clinical scores factored in, but usually those feature as secondary outcomes. And I wonder, given that what really matters to patients is the clinical outcome at 3 months, whether they're independent subsequently, whether as a community we have focused a little too much on demonstrating effect in the trials that have been done as opposed to clinical benefit. And I'd just be interested for your comments on those observations, particularly about drug interactions.
So I think both firstly in Japan and nimodipine in US and Europe are very good drug, but side effect is similar. Nimodipine and clazosentan. So combination effect is not good. So maybe combination of these drugs enhance the side effect, such as hypertension, anemia, and pulmonary edema. That is a problem. So if we try to use clazosentan, maybe monotherapy is better, I think, to get a good result.
Thank you. I don't know if we have any questions from the audience waiting.
Yes, I think we can take from the panelist, Dr. Liu. Dr. Liu is the Deputy Secretary of the ACNS and my co-host. He is in Japan. Please.
Thanks, Rajan. Thanks, Professor Suzuki, for a nice lecture. I mainly have two questions, Professor. One is your animal study on the intertaker of the drug, the clazosentan, even with 50% dose compared to intravascular. Do you find that the incidence of pulmonary edema, if you do study pulmonary edema in the animal study, is there a reduction in by using intertaker? And what do you think that the prospect using intertaker compared to IV in a human trial? My second question, Professor, you in your protocol for tachycardia you use beta blocker. Would the beta blocker safe in the patient with a risk of pulmonary edema with a combination of drug used for preventing vasospasm? Thank you, Professor.
Thank you for your question. The first question, in animal study, we did not check the pulmonary edema, but maybe pulmonary edema never occur because we inject clazosentan only intrathecally, in a very small dose, I think. And in clinical experiment, beta blocker is used to reduce tachycardia because we prefer to use cilostazol. The side effect, famous side effect of cilostazol is tachycardia. So severe hemorrhage induced heart failure and cilostazol side effect sometimes cause tachycardia and hypotension. So we use beta blocker to control heart rate and keep blood pressure.
Thank you, Professor.
Thank you, Liu, and thank Prof. One, I would like to ask Professor for his comments on two specific trials that came up. First is the from your own country by Professor Hidetoshi Kasuya, from where he first implanted the nicardipine pellets. What is your suggestion regarding this?
For nicotine pellet,
Yes.
that is a good choice, but off-label, and we can, in general, we can not use nicotine pellet.
Okay. The other thing that caught my attention was the Montreal protocol of using Milrinone. I usually use this in our center for preventive vasospasm. It is a deviation from the original protocol. I use it for less than a week and have found such good results. Not like we have not examined it systematically in a randomized control trial, but it is I think is a good drug when compared to conventional nimodipine. Have you had any experience regarding giving Milrinone?
Pardon?
The question is regarding giving Milrinone infusion, which is the Montreal protocol for preventive vasospasm. Okay, that's fine. I think you have not used it. Thank you. What about in your place, Professor Walsh?
Um, again, this is another agent that is sporadically used in the UK. So within London, I'm conscious of two large units. One that uses it very routinely and is very enthusiastic. At least the critical care team are very enthusiastic about its benefits in DCI. In my own unit, there's a much greater reluctance, partly because we look after patients in a mixed neuroscience critical care setting. So the intensive care physicians are also looking after cardiac patients in parallel. And that experience seems to make them more conscious of using Mirinolone because of the doses required to elicit the effect and the associated cardiotoxicity that sometimes arises. I'd love to see a really well controlled, properly powered, randomized trial to help me know if it's a good thing or a bad thing. But at the moment, I really don't know.
Yes, I think so.
Thank you very much. So now we'll wind up this session. We will take final closing remarks from our Honorable Chair.
Well, thank you very much. I mean, it's a fascinating tour through not only what's available to try and mitigate the effects of delayed cerebral ischemia, but I think it also illustrated really well the significant differences in standard protocols for the general care of a patient with brain hemorrhage around the world. And I think there's much to learn and much to look at in a research setting within that as well. One of the my own feeling as the years have gone by is I've tended to move towards less is more with DCI. I'm very interested in the potential for things like more aggressive CSF drainage and controlled CSF pumps to mitigate DCI going forward. And I think there's lots of exciting things on the horizon. But so many of these very promising drugs in phase 1 and phase 2 have just simply not translated. Whether we're talking about MASH or STASH or most recently in the UK the SKILL trial looking at an interleukin inhibitor. So I applaud the hard work being carried out by neurosurgical scientists like Professor Suzuki, and I encourage him to keep going and tell us more about what's going to help these people.
Thank you very much for those wonderful comments. So I would like to thank both the speaker and chair, Professor Suzuki and Professor Walsh, for taking out that precious time and educating the young neurosurgeons of the world. Thank you very much. Now it's time. We'll move on to the second session. I would like to hand over this podium to our Honorable Chair of the second session, Dr. Hasikawa, who will say a short introduction and invite our second speaker. Yes, Prof.
Okay, thank you very much. So good day, everyone. My name is Hirotake Hasegawa from Saitama Medical Center, Saitama Medical University. I'm extremely honored to welcome you to this session on endoscopic transnasal skull surgery in the pediatric population. I also extend my gratitude to the ACNS committee for organizing this great webinar and to our esteemed speakers for sharing their expertise. So compared to adults, the pediatric skull base is a complex and evolving anatomical structure. The narrower space and ongoing craniofacial growth add layers of complexity that demand meticulous planning. Additionally, the pathology encountered in pediatric cases are often different from those in adult, each requiring a nuanced approach. Endoscopic transnasal approaches have revolutionized pediatric skull base surgery, which is what I believe, by minimizing the need for invasive craniotomies, thus preserving critical neurovascular structures and reducing post-op recovery time. In pediatric patients, this translates into fewer complications and the preservation of normal development, which is a significant advantage both functionally and psychologically. Recent advancements, such as high-definition endoscopy and image-guided navigation, have expanded our ability to operate within narrow corridors with remarkable precision. Innovations in reconstructive techniques, such as vascularized nasostapler flaps and dural suturing, have also mitigated the risk of CSF leakages, further improving outcomes. So now, we are privileged to have a renowned expert presenting his latest research and case experiences. Without further ado, I am delighted to introduce our speaker, Dr. Chan Zhao, who will present on endoscopic transnasal surgery for skull-base lesions in children. So, Professor, please start your lecture. Thank you very much.
Thank you, Professor Hasegawa. Dear Chairman and the colleagues, good evening. Let me share my screen. Great honor for me to be here for this opportunity to share my work, some of my work and experience. My topic is endoscopic transnasal approach for treatment of skull-base lesion in children. In the past 20 years, endoscopic transnasal surgery, the ETNS, has developed considerably in terms of the advances in surgical devices and techniques, and the experience gained in performing these procedures in adults was subsequently utilized for the pediatric patients. And as we all know, most skull-base lesions in children were located in the midline, such as the cerebral region, pineal region, clavicle region is fourth ventricular. And so the ETNS has its unique advantages. This approach can keep the integrity of craniofacial bone structure, and the hypothalamic and pituitary axis were primarily protected. The ETNS was used in children as much later than in the adults for these main reasons. The small nostril, narrow nasal corridor, poor pneumatization of the sphenoid sinus, and the lack of the dedicated surgical instrumentation. Although the ETNS was difficult to implement in children, in the past 2 decades, they still have been actively explored and implemented by the neurosurgeons around the world. And the patients receiving the ETNS was become younger and younger. And in 2019, a scholar from the Germany, summarized the limitation of the endoscopic transnasal approach in young children, and they offered some options for these limits, such as the smaller endoscope, smaller instruments, use of the neural navigation, use the angled endoscope, and the smaller graft usage, and etc. And in 2021, the team from Pittsburgh reported their experience using ACNS in younger children. The age ranged from the 1.6 to 6.5 years old. The data showed the most common disease in the young children was craniopharyngioma and the encephalocele, and the craniopharyngioma was relatively prone to recurrence. With the application of the nasal septum mucosal flap, the occurrence of the CSF leak was significantly reduced. And here I summarized our cases. Our team started using the ACNS in pediatric patients in 2018, and we have finished 147 cases. Mainly were germ cell tumors, about 40%, and the craniopharyngiomas about 1/4. And the rest were Langerhans histiocytosis, pituitary adenoma, Raschke cyst, astrocytoma, and the chordoma. We have no encephalocele case because our hospital is the general hospital, not the children's hospital. So there were very few cases of congenital disease. And the age of the case ranged from 20 months to 18 years old. Median age was 9 years old. And about half the cases were in the age ranged from 6 to 10 years old, and about 15% were younger than 6-year-old. And their main initial symptom included the polyuria and polydipsia, about 40%. Growth retardation, about 20%. Headache or dizziness, about 15%. Impaired vision, about 10%. And precocious puberty, about 5%. And others such like obesity and menstrual disorder. And here I show 4 cases that we did. The case 1 was a 5-year-old girl suffered from the polyuria and polydipsia for 3 months. And the tumor marker for germ cell tumor was negative. The MRI showed the cellular lesion, and the pituitary stalk was involved. And we did the ACNS for biopsy using the Karlstorff's endoscopic system and the pneumatic arm. And these were the intraoperative photos. We can see that the sphenoid opening is not fully informed. After the anterior wall was removed, we can find the poor pneumatization of the sphenoid sinus. So we needed to remove the bone at the bottom of the cerebral region by the drill with the kind of the neural navigation. and we use the Medtronic electromagnetic navigation system. And this is a video of the procedure. And before we begin to write, we use the probe to confirm the position and the direction. And we start with the cortex of the bone. Just like this, it's white and hard. And inside the cortex of the bone, we can find the cancellous bone. It was gray and a little bit soft. And when the cancellous bone was removed, we again encountered the cortex of the bone. It's still white and hard. And it means we are approaching the cellular dural. We should be careful because sometimes the neural navigation is not so accurate. And during the grading procedure, we needed to constantly to use the probe to confirm the position and the direction. So when the dura was exposed, we could gradually expand the bone window depending on the observed anatomy of the skull base. And for this case, we exposed the dura of the cellular floor and the tubercle. And we cut open the yellow pituitary gland and found the gray lesion. Removed some tissue for pathology. Just like this. The final pathology confirmed the geminoma, so she advanced further chemotherapy and radiotherapy. And the second case is a 6-year-old boy. He suffered from the diplopia for 3 weeks. The CT and MRI showed the clival lesion. We did the ACNS for tumor resection. Similar to case 1, the sphenoid sinus was poorly pneumatized. And after remove the cortex and the cancellous bone, the tumor of the clivus was exposed, and it was gray and soft, and some of the tumor like the cartilage. And the blood supply is relatively abundant. And the exposure was enlarged as the tumor was removed. The tumor was finally totally removed, and we should take care to check that there was no residue in the peripheral epidural space near the bone window. And this is the picture of the cellar and the clival after tumor was removed. And the post-operative IMI contrast showed the total resection of the tumor. The final pathology showed chordoma, and she had went further radiotherapy. And the third case is a 9-year-old girl complained of blood region for 2 months. The CT and MI showed joint cellular region tumor with polycystic change and the calcification. Our preoperative diagnosis was craniopharyngioma. We also did the ACNS for tumor resection. And the dura requires more exposed in the direction of the anterior skull base. And cut open the dura and isolated the arachnoid membrane. We exposed the tumor, and we resected the tumor between the optic chiasma and the pituitary gland. Here is the chiasma, here is the pituitary gland. And the tumor was tenacious. And this is the calcification. We resected the tumor by pieces. And we exposed the apex of the basal artery. Because of the time, I can't play the whole video. The tumor adhered significant to the surrounding tissue. We dissected the wall, and finally, we totally removed the tumor. After tumor resection, we can find the third ventricle. And these are the photos after tumor resection. We can find the floor of the third ventricle was fully opened. And we can see the bilateral mons foramen and the thalamostrate vein and the fornix and the aqueduct. And the apex of the basal artery was also exposed, and the PCA, the artery were well protected. And the post-operative CT and MI demonstrated the tumor was totally removed. The pathology confirmed the adamantinomatous craniopharyngioma. Unfortunately, the girls eventually died of the septic shock from the severe intracranial infection. And the last case is a 4 years old girl suffered from the headache and vomiting for 1 week. The tumor marker was negative, and the CT and MRI showed a cellular lesion. We also did the ACNS. In the same way, we cut open the dural and the rhabdoid membrane, and we exposed the tumor. We also resect tumor between the chiasma and the pituitary gland. The tumor was medium texture. The boundary was very clear. And this is the pituitary stalk. And after we cut off the pituitary stalk, we resect the tumor by pieces, and the tumor was closely related to the optic chiasma and the floor of the third ventricle. We dissected the tumor's surrounding tissue, and finally, tumor was totally removed. And these are photos before and after the tumor resection. And we can see the open third ventricle and the bilateral mammillary body and the apex of the basilar artery. The post-operative MRI demonstrated the tumor was totally removed, and the pathology revealed the pelomycete astrocytoma, and the patient was well and has been followed to date. So in our cases, except the diseases such as the geminoma or the lung cancer histocytoma, which required biopsy only. In the remaining 71 cases, such as the craniopharyngioma, pituitary adenoma, cyst, glioma, we aimed to remove the tumor totally before surgery. Finally, total resection was achieved in 68 cases, and achieved a near total resection in 2 cases. Only 1 case we just do the partial resection, so the total resection rate was more than 95%. And this is the method we used to repair the skull base. And this article comes from the Pittsburgh. We used the method. A 3-layer structure is mainly utilized. The most inner layer is a coating graft. Then the facial ladder graft, and finally the nasal septal flap. And for the cases has a bone defect of the slope, the fat tissue graft was used to fill with. And the common post-operative complication included the diabetes insipidus and the electrolyte disturbance and CSF ranurial and intracranial infraction. The CSF ranurial occurred in our cases. There's 40 cases, and in which 31 cases were complicated with intracranial infection. And here we define the CSF rhinorrhea as a continuous flow-out of the CSF from the nostril after surgery, and that required the lumbar cisternal drainage. And unlike some literature that defined it as the CSF rhinorrhea as requiring re-operation for reparation, we just defined the CSF leak from nostril after the surgery. And the management of the post-operative CSF rhinorrhea consists of the continuous lumbar drainage, 50 to 70 microliter every 8 hours, and we usually use some antibacterial to prevent or treat the intracranial infection. If the treatment does not resolve the rhinorrhea within 2 weeks, reparation should be considered in our 50 cases, 18 cases underwent the reoperation. In the 18 cases, 11 cases were craniopharyngioma cases, and 10 of them had an intracranial infection. We think it may be due to the complete opening of the cerebroventricular floor after the tumor resection, and the flow of the CSF leakage is relatively higher than the other diseases. So according to our data and the literature, we can make a summary. The ACNS for pediatric scalp-based lesion is safe and effective. The total resection rate is higher, and the complication rate of the post-operative CSF rhinorrhea is higher, but most cases can be controlled and cured by the continuous lumbar drainage. And the children with the CSF rhinorrhea has a high risk for the intracranial infection, especially after the craniotomy resection. That's all. Thank you.
Oh, thank you very much. Thank you very much for Professor Chao. It's a wonderful lecture with a beautiful surgical videos and a nice concept to prevent CSF leakage. As you mentioned, the risk of CSF leakage remains high, particularly for craniopharyngiomas and some other skull-based intradural lesions, right?
Yeah.
What you think is the most important? I mean, based on your personal experiences, based on what you have seen around the world, what do you think is the most important to prevent CSF leakage for such particular cases?
I think the most thing is first we should prevent the CSF leakage in the operation. First, we can do the minimal invasive as possible as we can, and just maybe in our series, just half of them we opened the suprasellar region, some of the cases we just opened the floor of the cellar region, and there's no CS leakage in these cases. And for the cases we have to open the supercellular region, and we should do I think do the very good reparation to prevent the CS leakage. We need to do the we need to take the facial lateral to do the reparation. We need to use the collagen graft and the nasal septal flap. And I think this is a nasal septal flap is very important to repair the leakage.
Do you have any comment on the usage of rigid reconstruction, like plate or bone plate or that kind of things?
You mean use the bone graft?
Yeah, something like that, bone or the metal plate or plastic plate.
For the very high flow of the CS leakage, we will use the some like the bone graft or something, the hard artificial dural. We will use it. But most cases we just need to the 3-layer graft, just the collagen, the nasal septal. I think in most of cases we use the 3 layers is enough to prevent the CSF leak.
Okay, sounds great. What do you think about dural suture? Because that's kind of my
I know. We tried to do these, suture in several cases. I think in the pediatric patients, it's very difficult to do the suture. For the adult patients, maybe we can try to do the suture, maybe 1 or 2 to fix the artificial dural or the septal. But in pediatric patients, it's very difficult. Usually we will use a glue to fix the collagen or the flap.
Okay, sounds great. So actually, we have several questions from audience. So the one question is, what was the size of the rongeur and endoscope? Do you use a binostrils approach?
It's a regular endoscope.
Like 4 millimeter?
It's a regular. What is?
I think regular endoscope is 4 millimeter in diameter.
Yeah, it's maybe 5 to 6 to 7.
Oh.
Okay, it's regular and
yes, make us.
I understood.
It's closed.
Okay, fine. If there are can
5
invite comments.
to 6
millimeters. Fine, thank you. Any questions from Liu?
Yeah, thanks, Professor.
I use a binostril approach in pediatric patients.
Fine, thank you.
Okay.
What is your head position?
No. You said most of the questions you have answered in your lecture. That is why it is not there. Right.
We just put the head position.
You said
we not use the Mayfield extension.
Yeah, fine.
Yeah, we can skip that question. Sorry. So, Professor Liu.
Yeah. Thanks, Professor Zhang, for a nice lecture. May I know in your series, what are the youngest age, the youngest patient, and then do you have?
Is it 20 months?
20 months. Oh, okay. Do you have any tools that you use to measure or to predict to decide whether those patients are suitable to use endoscopic or not? Is there any technique or in terms of choosing the patient? Do you measure the nostril opening, or you do incision over the nasal skin, or you use electromagnetic navigation? Thank you, Professor.
Yeah, usually I will use the navigation, and for the patient choose, I think it's the most important thing is to the location of the lesion. I think the if the lesion is located intracellular or intracellular and supracellular, and we can try to use the ACNS. And if the tumor or the lesion located in supracellular and the maybe in the third ventricular, and maybe we do the it's better to we do the craniotomy. Yeah.
Thank you.
It's wrong.
Thank you. One comment I would like to make is that you have mentioned wait for 2 weeks to CSF leak to resolve. I think 2 weeks
see
is
me?
yes, we can see you.
Okay.
In your lecture, you mentioned that you wait for 2 weeks after lumbar puncture to see if the CSF leak subsides on its own. But I think in Japan it is very different, isn't it, Prof. Hasegawa? How long would you wait if there is a CSF leak? I understand there won't be a CSF leak because you are suturing.
I mean, I don't think I will wait longer than 2 days because the longer you wait, the higher the risk
infection
of
rate
is become. So I'm actually curious about your strategy to prevent the meningitis and eventually prevent the neurological deterioration as a sequel of the meningitis.
Yes, that is what also Prof. Watanabe does in AMC. Like if there is a leak, you go and repair it. Why should you wait? Is his policy. But different centers follow different protocol. I understand that. So thank you very much, Prof. Chang Chao, for this wonderful presentation. We would like to have the concluding remarks from Prof. Hasegawa.
Okay, sounds good. So as we conclude this enlightening session, I'd like to express my sincere gratitude to our esteemed speakers for their exceptional presentations and insights. Their dedication to advancing the field of pediatric skull-based surgery and cerebral vascular ischemia are truly inspiring. And I also extend my thanks to the ACNS organizers for facilitating this platform for knowledge exchange and collaboration. So as we go over briefly, today we have covered 2 interesting topics. One is from Professor Suzuki, mainly about cloud center usage and insight into how to reduce delayed cerebral ischemia. The second lecture was from Professor Chao, highlighting critical advancements in neuroendoscopic technology and surgical techniques that continue to enhance precision and safety in pediatric cases based on his rich experience. So I like to encourage everyone to share their experience, insights, and ideas as we strive to refine techniques and improve standards of care. And finally, I'd like to thank all of you, the attendees, for active participants and engagement. And your contributions have made this session a dynamic and meaningful exchange. Once again, thank you for joining us. Let us continue to advance our practice with both precision and compassion. I look forward to our future discussion and collaborations. Please stay safe and hope to see you all at future ACNS events. Thank you very much.
Well, thank you very much for those nice words. We are extremely grateful. So now I'd like to close this officially now on behalf of the Education Committee of the ACNS and the President, Prof. Yuko Kato. I would like to thank both the speakers of today, Prof. Hidenori Suzuki and Professor Chang Chao, as well as the chairs, Professor Daniel Walsh and Professor Hirotaka Hasegawa, for the time and support for the ACNS webinars. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.